Question 1. A patient on hemodialysis develops severe muscle cramping during the last hour of treatment, despite a properly calculated ultrafiltration goal. Which intervention is most appropriate to mitigate this symptom immediately?
A.
Administer a rapid infusion of normal saline 0.9% NaCl.
B.
Reduce the ultrafiltration rate, UFR, and administer 100 milliliters of 23% hypertonic saline.
C.
Place the patient in Trendelenburg position and increase the blood flow rate, BFR.
D.
Decrease the dialysate temperature and increase the dialysate sodium concentration. Answer. B. Reduce the ultrafiltration rate, UFR, and administer 100 milliliters of 23% hypertonic saline. This question tests the management of intradialytic complications, specifically severe muscle cramping, which is often caused by hypovolemia or rapid fluid removal. The most effective immediate intervention is to reduce the stress on the patient's circulatory system by lowering the ultrafiltration rate, UFR, and giving a small volume of a highly concentrated sodium solution. Hypertonic saline, such as 23% NaCl, quickly draws fluid back into the bloodstream from the interstitial space, rapidly restoring plasma volume and relieving the cramping. A quick, targeted sodium boost is often necessary to correct the underlying fluid shift that causes the muscle spasm. Remember that while large volume saline can help, hypertonic saline provides a faster, more effective osmotic pull. Question 2. A patient with end-stage kidney disease, ESK, is prescribed sevelamer carbonate. Which laboratory value should the nurse prioritize monitoring to determine the effectiveness of this medication?
A.
Serum creatinine.
B.
Intact parathyroid hormone, IPTH.
C.
Serum phosphorus.
D.
Serum calcium. Answer. C. Serum phosphorus. The concept tested here is the mechanism of action for phosphate binders in the management of chronic kidney disease mineral and bone disorder. Sevelamer carbonate is a non-calcium, non-aluminum phosphate binder that works by binding with dietary phosphate in the gastrointestinal tract, preventing its absorption into the blood. Therefore, a decrease in the patient's serum phosphorus level is the direct indicator of the medication's effectiveness in controlling hyperphosphatemia. While IPTH and calcium are related components of CKD-MBD, phosphorus control is the primary target of this specific drug therapy. Controlled phosphate levels are crucial because uncontrolled hyperphosphatemia contributes to both bone disease and vascular calcification. Question 3. During a routine quality check, a nurse notes a positive result on the residual chlorine test after the primary carbon filter on the reverse osmosis, RO, water treatment system. What is the immediate priority action?
A.
Continue the treatment and retest in 1 hour.
B.
Immediately place all hemodialysis machines into bypass mode.
C.
Increase the frequency of backwashing the multimedia filter.
D.
Change the secondary carbon filter and document the event. Answer. B. Immediately place all hemodialysis machines into bypass mode. This question evaluates the nurse's critical decision-making regarding water treatment safety, a key component of the CDN exam. A positive chlorine or chloramine test after the primary carbon filter indicates that the filter has been exhausted and is no longer removing disinfectants, allowing them to enter the dialysate. Exposure to even trace amounts of chlorine and chloramines can cause acute, severe hemolysis, destruction of red blood cells in dialysis patients, making the immediate termination of patient treatments and activation of the bypass mode the only safe action. The other actions are maintenance or delayed responses. Patient safety dictates that dialysis must stop immediately to prevent a massive transfusion reaction. Question 4. A patient is receiving continuous ambulatory peritoneal dialysis. The nurse observes the outflow to be cloudy with fibrin strands. The patient reports abdominal pain and a low-grade fever. Which differential diagnosis is most likely, and what is the initial management?
A.
Peritoneal protein loss. Initiate albumin infusion.
B.
Peritonitis. Obtain a peritoneal fluid cell count and culture and administer empirical antibiotics.
C.
Ultrafiltration failure. Increase the dextrose concentration of the dialysate.
D.
Fibrin clot formation. Administer a small dose of unfractionated heparin into the next well. Answer. B. Peritonitis. Obtain a peritoneal fluid cell count and culture and administer empirical antibiotics. This item tests the nurse's recognition and initial management of the most common and serious complication of peritoneal dialysis, peritonitis. Cloudy effluent, abdominal pain, and fever is a classic triad signaled by the inflammation, which is most often caused by a bacterial infection. The immediate priority is to obtain a sample for diagnostic testing, specifically a cell count and culture, and to start broad-spectrum, empirical antibiotics immediately without waiting for culture results to prevent systemic sepsis. While fibrin can be present, the pain and fever point directly to an infection, and simply treating the fibrin would miss the underlying life-threatening problem. Question 5. A 68-year-old male with a history of heart failure and spKt is prescribed a dry weight of 75 kilograms. His pre-dialysis weight is 78.5 kg, and he is scheduled for a 4-hour treatment. Given a required rinse-back volume of 0.5 kg, what is the minimum acceptable ultrafiltration rate, UFR, needed in ml/HR, assuming no oral intake during the session?
A.
750 milliliters per hour.
B.
875 milliliters per hour.
C.
1,000 milliliters per hour. D. 1,200 milliliters per hour. Answer. C. 1,000 milliliters per hour. This question tests the calculation of the required ultrafiltration rate, UFR, a foundational skill in hemodialysis. The total fluid to be removed is the difference between the pre-dialysis weight and the dry weight, plus the required rinse-back volume. The total fluid removal, TFR, is calculated as 78.5 minus 75 plus 0.5 equals 40. 78.5 kg minus 75 kg plus 0.5 kg equals 40 kg, which converts to 4,000 milliliters. Since the treatment time is 4 hours, the minimum UFR is found by dividing the total volume by the time. 4,000 ml
slash
4 hours equals 1,000 ml/HR. 4,000 ml/4 hours equals 1,000 ml/HR. An accurate UFR calculation ensures that the target weight is reached without causing harmful hypotensive episodes from excessively fast fluid removal. Question 6. A patient complains of shortness of breath and chest pain that started shortly after initiating hemodialysis. The nurse notes hypotension, muffled heart sounds, and jugular venous distension. What is the most likely cause, and what emergency intervention should the nurse prepare for?
A.
Air embolism. Place the patient in Trendelenburg position on the left side.
B.
Hemolysis. Stop dialysis and administer oxygen.
C.
Cardiac tamponade. Initiate immediate preparation for pericardiocentesis.
D.
Dialyzer reaction, type I. Administer epinephrine and stop the blood pump. Answer. C. Cardiac tamponade. Initiate immediate preparation for pericardiocentesis. This scenario describes a classic presentation of cardiac tamponade, a life-threatening complication where fluid accumulates in the pericardial sac, compressing the heart. The critical clinical triad, known as Beck's triad, is the combination of hypotension, muffled heart sounds, and JVD, which should be the key clues pointing to this diagnosis. The definitive treatment for cardiac tamponade is a pericardiocentesis, which involves draining the fluid to relieve the pressure on the heart and restore cardiac function. While the other options represent serious complications, the specific cluster of symptoms strongly suggests cardiac tamponade, requiring rapid recognition and intervention. Question 7. Which finding in a patient's monthly laboratory results is the strongest indicator of inadequate long-term dialysis clearance and necessitates a review of the prescription?
A.
Blood urea nitrogen BUN of 85 milligrams per deciliter pre-dialysis.
B.
Single pool KT/V spKt/V of 1:1.
C.
Hemoglobin V of 9:0 G/DL.
D.
Serum albumin of 3:0 G/DL. Answer: B. Single pool KT/V spKt/V of 1:1. This question tests the understanding of dialysis adequacy monitoring using established quality metrics. The single pool KT/V spKt/V is the gold standard measurement used to assess the effectiveness of solute clearance, with the recommended minimum target for adequate hemodialysis being 1:2 per treatment. An spKt/V value of 1:1 is below this benchmark, which is the strongest direct evidence of inadequate long-term dialysis clearance, requiring immediate investigation and possible prescription adjustment, such as increasing treatment time or dialysis size. While a high BUN or low hemoglobin are concerning, they are less specific to clearance adequacy than the calculated KT/V, which specifically measures urea removal. Question 8. A nurse is preparing to initiate hemodialysis on a patient with a newly placed arteriovenous AV graft. Which assessment findings should prompt the nurse to immediately notify the nephrologist and hold the cannulation?
A.
A strong, easily palpable thrill over the access site.
B.
A loud, continuous bruit heard through the entire cardiac cycle.
C.
Palpable warmth, erythema, and tenderness localized to the anastomosis site.
D.
A palpable pulse distal to the graft with good capillary refill. Answer: C. Palpable warmth, erythema, and tenderness localized to the anastomosis site. The concept here is the crucial pretreatment assessment for an AV access, specifically recognizing signs of infection. Localized warmth, redness, erythema, and tenderness, especially near the connection point, anastomosis, are classic signs of a localized infection, which is a major complication in a new or established access. Cannulating an infected access is strictly contraindicated as it can introduce bacteria directly into the bloodstream, leading to a life-threatening systemic infection, sepsis, and potentially destroying the graft. A strong thrill and a continuous bruit are actually desired findings, indicating good blood flow and patency, which is why the nurse should focus on the inflammatory signs. Question 9. In a patient with chronic kidney disease spKt on maintenance hemodialysis, which finding is most consistent with uremic neuropathy?
A.
A positive Chbostek sign.
B.
Restless legs syndrome, especially at night.
C.
A sudden onset of severe, throbbing headache.
D.
Flapping tremors, asterixis of the hand. Answer: B. Restless legs syndrome, especially at night. This question tests the nurse's knowledge of the common neurological manifestations of advanced uremia. Uremic neuropathy is a form of peripheral neuropathy, and the most common presentation is the sensory motor disturbance known as restless leg syndrome, RLS, or Willis-Ekbom disease, characterized by an uncontrollable urge to move the legs, especially during periods of rest or at night. While asterixis can be seen in severe uremia, uremic encephalopathy, RLS is the most frequent and classic presentation of uremic neuropathy. Recognizing this specific symptom is key because RLS often responds to improved dialysis adequacy or specific pharmacological treatment. Question 10. A patient on hemodialysis consistently presents with pre-dialysis serum bicarbonate levels of 15 milliequivalent/L, normal range 22 to 26 milliequivalent/L. The dialysis prescription should be adjusted to address this chronic metabolic acidosis primarily by
A.
Increasing the treatment time by 30 minutes.
B.
Increasing the dialysate flow rate (CT).
C.
Increasing the dialysate bicarbonate concentration.
D.
Switching to a larger surface area dialyzer. Answer: C. Increasing the dialysate bicarbonate concentration. This item tests the management of chronic metabolic acidosis in dialysis patients, a key element of acid-base balance. Metabolic acidosis, indicated by the low bicarbonate level, is corrected during dialysis by the diffusion of bicarbonate from the dialysate into the patient's blood. The most direct and specific way to increase bicarbonate delivery and correct the acidosis is by increasing the concentration of bicarbonate in the dialysate itself. While increasing treatment time or flow rates will generally improve clearance, changing the dialysate bicarbonate concentration is the targeted intervention for correcting a persistent acid-base imbalance. The goal is to maximize the concentration gradient to facilitate bicarbonate transfer back to the patient. Question 11. Which factor poses the highest risk for developing dialysis disequilibrium syndrome (DDS) during the initial hemodialysis treatment?
A.
A high baseline serum albumin level.
B.
A very high pre-dialysis blood urea nitrogen (BUN) level, e.g., greater than 150 milligrams per deciliter.
C.
An ultrafiltration rate, UFR, set above the facility's maximum limit.
D.
Use of a high-flux, high-efficiency dialyzer. Answer: B. A very high pre-dialysis blood urea nitrogen (BUN) level, e.g., greater than 150 milligrams per deciliter. This question assesses the understanding of the pathogenesis and risk factors for dialysis disequilibrium syndrome (DDS), a serious first-time complication. DDS is caused by a rapid decrease in the concentration of solutes, like urea, in the patient's blood, which creates an osmotic gradient that draws water into the brain cells, leading to cerebral edema. The biggest risk factor for this rapid shift is a very high pre-dialysis BUN level, making the initial solute concentration difference between the blood and brain extreme. To prevent DDS in such high-risk patients, treatments are typically started shorter and slower to gradually reduce the blood urea concentration. Question 12. A nurse observes a red-tinged discoloration in the arterial blood line proximal to the dialyzer, followed by dark, transparent urine output from the patient. The patient reports back pain and a feeling of warmth. What type of reaction is the nurse most likely observing?
A.
Anaphylaxis. Type A dialyzer reaction.
B.
Acute intravascular hemolysis.
C.
Pyrogenic reaction.
D.
Air embolism. Answer: B. Acute intravascular hemolysis. This scenario describes the classic, critical signs of acute intravascular hemolysis, which is the massive destruction of red blood cells, RBCs, in the bloodstream. The red-tinged blood in the line, a phenomenon called cherry red blood, is a direct visual cue, and the back pain and warmth are common initial patient complaints before more systemic symptoms. The passage of free hemoglobin through the kidneys causes the dark, transparent urine hemoglobinuria, which is highly indicative of this complication. Hemolysis is often caused by chemical issues like chlorine contamination in the water or overheating of the dialysate, and its prompt recognition is essential to prevent acute kidney injury. Question 13. A patient's arteriovenous fistula, AVF, has been successfully cannulated and the treatment is under A. The venous pressure alarm consistently sounds at a high level, e.g., greater than 250 millimeters of mercury, and the nurse notes mild swelling in the extremity distal to the axis. What is the most likely cause of this high-pressure alarm?
A.
Needle dislodgement or kinking of the arterial line.
B.
Venous outflow stenosis or the needle tip resting against the vessel wall.
C.
Excessive dialyzer clotting due to inadequate anticoagulation.
D.
Hemolysis due to high blood pump speed. Answer: B. Venous outflow stenosis or the needle tip resting against the vessel wall. This question tests troubleshooting knowledge related to access pressures, where the high venous pressure alarm is a primary clue. High venous pressure indicates an obstruction or increased resistance to blood flow after the blood leaves the dialyzer and returns to the patient via the venous needle. The combination of a high venous pressure alarm and swelling distal to the axis strongly suggests venous outflow stenosis, narrowing of the vein or a mechanical blockage, like the needle tip pressing against the vessel wall. Needle dislodgement or arterial line kinking would affect the arterial pressure, while dialyzer clotting would cause a high transmembrane pressure. Question 14. A patient on peritoneal dialysis presents with the classic symptom of scanty or small volume outflow, but no signs of infection. The nurse confirms that the inflow volume was correct. Which action should the nurse attempt first to improve drainage?
A.
Reposition the patient, such as by ambulating or changing the side-lying position.
B.
Administer an enema or laxative to relieve abdominal constipation.
C.
Increase the amount of dextrose in the next exchange.
D.
Manually flush the peritoneal catheter with sterile normal saline. Answer.
A.
Reposition the patient, such as by ambulating or changing the side-lying position. This tests the first-line troubleshooting for peritoneal dialysis catheter outflow problems that are not related to infection. The most common cause of poor outflow, scanty drain, is the catheter tip being temporarily occluded by omentum, which is a fold of fatty tissue in the abdomen, or by simply resting against the peritoneal wall. The easiest, least invasive first step is to reposition the patient, such as having them stand up, roll side to side, or use the bathroom to move the catheter tip away from the obstruction. While constipation can be a cause, repositioning is the immediate, non-pharmacological intervention before moving on to more aggressive measures like prescribing a laxative. Question 15. The nurse administers an iron sucrose injection during hemodialysis. The patient immediately develops wheezing, generalized urticaria, and a sudden drop in blood pressure. The immediate priority intervention is to
A.
Stop the iron infusion, administer epinephrine, and return the patient's blood.
B.
Stop the iron infusion and administer a stat dose of diphenhydramine and hydrocortisone.
C.
Stop the iron infusion and blood pump, clamp the venous line, and call for emergency assistance.
D.
Decrease the blood flow rate BFR, flush the venous line with normal saline, and monitor vital signs closely. Answer. C. Stop the iron infusion and blood pump, clamp the venous line, and call for emergency assistance. This question addresses the critical, immediate response to an anaphylactic reaction, a life-threatening complication of for iron administration. The combination of wheezing, hives, urticaria, and hypotension points to a severe, systemic hypersensitivity reaction, anaphylaxis. The immediate priority is to stop the infusion and the dialysis treatment to prevent any further exposure to the allergen and to protect the patient's blood volume by clamping the venous line and calling for the rapid administration of emergency medications. Stopping the iron infusion and the blood flow must precede or occur simultaneously with the epinephrine administration for complete patient safety. Question 16. What is the most significant clinical concern when a patient receiving a standard hemodialysis prescription consistently has a pre-dialysis potassium level of 6, 8 milliequivalent/L?
A.
Risk of muscle cramping due to rapid potassium removal.
B.
High risk of life-threatening cardiac dysrhythmias.
C.
Increased risk of clotting in the extracorporeal circuit. D. Risk of dialysis disequilibrium syndrome. Answer. B. High risk of life-threatening cardiac dysrhythmias. This question tests the understanding of the clinical urgency associated with severe hyperkalemia in dialysis patients. A pre-dialysis potassium level of 6, 8 milliequivalent/L is critically high and significantly increases the patient's risk for ventricular dysrhythmias, which can rapidly progress to cardiac arrest. Although rapid potassium removal can sometimes cause symptoms, the pre-dialysis danger of severe hyperkalemia is the immediate cardiac toxicity. The nurse must prioritize initiating treatment with a dialysate potassium bath of 1 to 2 milliequivalent/L and ensuring immediate continuous cardiac monitoring to safeguard the patient's heart function. Question 17. The primary purpose of ultrafiltration profiling in hemodialysis is to
A.
Adjust the sodium concentration in the dialysate to prevent intradialytic hypotension.
B.
Vary the rate of fluid removal throughout the treatment to match the patient's plasma refill rate.
C.
Ensure the total prescribed fluid volume is removed in the shortest possible time.
D.
Automatically adjust the blood flow rate, BFR, based on the patient's blood pressure. Answer: B. Vary the rate of fluid removal throughout the treatment to match the patient's plasma refill rate. This question assesses the specific function of ultrafiltration profiling, a key feature in modern dialysis management. Ultrafiltration, UF, profiling is a technique that changes the UF rate over time, typically removing fluid more slowly at the beginning and end of the treatment. The main goal is to prevent hypotension by matching the rate of fluid removal from the blood with the rate at which fluid moves from the tissues back into the blood vessels, plasma refill. This customized approach helps maintain a more stable blood volume and reduces the risk of symptomatic low blood pressure during treatment. Question 18. A patient is prescribed cinacalcet, a calcimimetic. The nurse understands that this medication works primarily by
A.
Directly binding to dietary phosphate in the gut.
B.
Increasing the absorption of calcium and phosphate from the GI tract.
C.
Increasing the sensitivity of the parathyroid gland's calcium-sensing receptor, CSR.
D.
Directly suppressing the synthesis and release of erythropoietin. Answer: C. Increasing the sensitivity of the parathyroid gland's calcium-sensing receptor, CSR. This question requires knowledge of the pharmacological management of secondary hyperparathyroidism, a core component of CKD-MBD. Cinacalcet is a calcimimetic agent, meaning it mimics the action of calcium on the parathyroid gland's calcium-sensing receptor, CSR. By making the parathyroid gland more sensitive to the existing serum calcium, the drug effectively lowers the release of parathyroid hormone P, thus treating the condition. Understanding this mechanism is vital because this drug directly affects the hormone axis, unlike phosphate binders or vitamin D analogs. Question 19. The nurse notes a significant decrease in the patient's transmembrane pressure, TMP, during the hemodialysis treatment, despite all other parameters, BFR, DFR, UFR, remaining unchanged. What is the most likely cause?
A.
Increased hematocrit due to hemoconcentration.
B.
A tear or leak in the dialyzer membrane.
C.
Progressive clotting of the dialyzer.
D.
Venous needle infiltration. Answer: B. A tear or leak in the dialyzer membrane. This question tests the advanced troubleshooting of machine pressures. Transmembrane pressure, TMP, is the pressure difference across the dialyzer membrane, which is the sum of the arterial/venous pressures and the dialysate pressure, and it is a key factor in driving ultrafiltration. A decrease in TMP, when all other settings are constant, most commonly indicates a breach or leak in the dialyzer membrane, causing the dialysate compartment pressure to equalize with the blood compartment pressure. Conversely, an increase in TMP is usually the sign of a clotted or partially clotted dialyzer. This leak can cause a blood leak into the dialysate and is an immediate patient safety risk. Question 20. Which dietary education topic is most critical for a patient who has a significant risk for recurrent oxalate kidney stones and is progressing to SKD?
A.
Restricting total fluid intake to reduce intradialytic weight gain.
B.
Avoiding high potassium fruits and vegetables.
C.
Limiting foods high in vitamin C, ascorbic acid, and oxalate.
D.
Ensuring a high-protein diet to maintain serum albumin levels. Answer: C. Limiting foods high in vitamin C, ascorbic acid, and oxalate. This question integrates nutrition and nephrology, specifically addressing oxalate stone formation in the context of kidney disease. For a patient at risk of oxalate stones, the key nutritional intervention is to limit the intake of high oxalate foods like spinach, nuts, and chocolate, and high-dose vitamin C, ascorbic acid, which the body metabolizes into oxalate. This is a crucial intervention because high oxalate levels, especially as kidney function declines, contribute directly to stone formation and worsening kidney damage. While other dietary restrictions are generally important, the oxalate restriction is specific and essential for this particular patient history. Question 21. A patient with a new peritoneal dialysis D catheter is being trained for home exchanges. Which instruction is the most critical to prevent touch contamination and subsequent peritonitis?
A.
Always wear a surgical mask during the exchange procedure.
B.
Wash hands with soap and water for at least 30 seconds before starting.
C.
Ensure the extension set is scrubbed with chlorhexidine before connecting the transfer set.
D.
Avoid touching the tip of the transfer set or the tubing connection points after disinfection. Answer: D. Avoid touching the tip of the transfer set or the tubing connection points after disinfection. This is a practical, infection control-focused question, testing the most critical step to prevent contamination. Peritonitis in PD is most often caused by touch contamination, meaning direct contact between a non-sterile object, like a finger or clothing, and the sterilized tip of the transfer set or the connection point. While hand washing and masking are important, the final and most critical action is maintaining the sterility of the connection point by not allowing it to be touched after it has been disinfected and prepared for connection. This simple act is the single most effective way to break the contamination pathway. Question 22. What is the primary reason for performing a showering technique, multiple needle sticks, during the cannulation of a complex, difficult arteriovenous fistula, AVF?
A.
To decrease the total blood pump speed required to achieve the prescribed blood flow rate.
B.
To minimize the risk of recirculation by spacing the needles far apart.
C.
To create multiple sites for future cannulation, preserving the entire length of the fistula.
D.
To distribute the shear stress of the needle over a larger area, reducing aneurysm formation. Answer: D. To distribute the shear stress of the needle over a larger area, reducing aneurysm formation. This question tests the advanced skill of access cannulation techniques. The showering, or area puncture technique, involves placing needles in a different, nonlinear location within a defined area of the fistula for each treatment. This practice's primary benefit is to distribute the needle stick trauma across a broader surface area, preventing repeated puncture at the same small spots, a fixed site technique, which would otherwise lead to the formation of localized weak spots, aneurysms, or pseudoaneurysms. The goal is to preserve the integrity and longevity of the vessel, which is paramount in dialysis access care. Question 23. A patient is prescribed a 50 mg maintenance dose of oral nifedipine to manage chronic hypertension. The nurse should educate the patient about the potential for nifedipine to interact with which common dialysis medication, potentially causing severe hypotension?
A.
Epoetin alpha, EPO.
B.
Calcitriol, active vitamin D.
C.
Phosphate binders, e.g., calcium acetate.
D.
For iron dextrin. Answer: B. Calcitriol, active vitamin D. This question tests the nurse's knowledge of complex drug-drug interactions in the dialysis population. Nifedipine, a calcium channel blocker, and calcitriol, active vitamin D, are both commonly prescribed, and their simultaneous use is known to cause severe, prolonged hypotension in some patients. This interaction is not fully understood, but may be related to their combined effects on calcium metabolism and vascular tone. The nurse must be aware of this specific, non-obvious interaction to counsel the patient on monitoring blood pressure and reporting any signs of dizziness or syncope. Question 24. A patient notes that their pre-dialysis weight is 5 kg below their prescribed dry weight. The patient is asymptomatic but reports feeling slightly weak. What is the most appropriate action for the nurse to take?
A.
Run the treatment at the prescribed ultrafiltration goal, UFG, and monitor vital signs closely.
B.
Initiate the treatment with a total fluid removal goal of 0 and notify the nephrologist.
C.
Administer a 250 milliliters bolus of normal saline and then reduce the treatment time by 30 minutes.
D.
Increase the dialysate sodium concentration to promote fluid shift. Answer: B. Initiate the treatment with a total fluid removal goal of 0 and notify the nephrologist. This tests critical thinking regarding dry weight assessment and the principle of not removing fluid unnecessarily. Since the patient is already below their target dry weight, they are effectively dry or even slightly underdialyzed for fluid. The immediate and safe action is to set the ultrafiltration goal, UFG, to 0 to prevent further fluid removal, which could lead to severe hypotension and hypovolemia. The nephrologist must then be notified to reassess the patient's dry weight, as the prescribed dry weight may now be too high for the patient's current clinical status. Question 25. Which statement accurately describes the main physiological difference between hemodialysis, D, and peritoneal dialysis, D?
A.
HD relies primarily on convection, while PD relies solely on diffusion.
B.
HD uses a semi-permeable membrane dialyzer, while PD uses the patient's own peritoneal membrane.
C.
HD removes middle molecules more effectively than PD.
D.
PD achieves a much faster rate of solute removal than HD. Answer. B. HD uses a semi-permeable membrane dialyzer, while PD uses the patient's own peritoneal membrane. This question tests a foundational understanding of the core mechanisms of renal replacement therapy. The most accurate physiological distinction is the type of membrane used for filtration and diffusion. Hemodialysis uses a synthetic, external semi-permeable membrane within the dialyzer, whereas peritoneal dialysis utilizes the patient's own peritoneal membrane, which lines the abdominal cavity, as the biological filter. While there are differences in solute removal and transport mechanisms like convection and diffusion, the distinction in the type of membrane is the most fundamental physiological difference. Question 26. A patient reports a sudden, burning pain radiating up the access extremity during the return of blood phase. The nurse immediately clamps the venous line and stops the blood pump. The nurse should suspect which complication?
A.
Venous needle infiltration.
B.
Venous air embolism.
C.
Potassium imbalance.
D.
Dialysate-related hemolysis. Answer.
A.
Venous needle infiltration. This question focuses on recognizing the specific signs of a common complication during the blood return phase. A burning pain radiating up the access extremity during the return of blood is the classic symptom of venous needle infiltration, which is the dislodgement of the venous needle, allowing blood to infuse into the surrounding soft tissues rather than the vein. This is an urgent situation because the high-pressure return of blood can cause significant tissue damage. The immediate response must be to stop the blood pump and clamp the venous line to prevent further infiltration, then apply pressure and ice. Question 27. When monitoring a patient during a dialysis run, the nurse notes that the venous chamber is foaming and the blood has turned a dark, purplish-red color. The patient is anxious and reports a metallic taste. This clinical picture is most suggestive of
A.
Dialyzer clotting.
B.
Air embolism.
C.
Hemolysis.
D.
Pyrogen reaction. Answer. C. Hemolysis. This scenario provides multiple strong clues pointing directly to acute hemolysis, red blood cell destruction. The combination of a metallic taste from the free hemoglobin and the visible change in the color of the blood to a dark, purplish red, often described as cherry red or port wine, is the hallmark sign of massive RBC breakdown. Foaming in the venous chamber is a less common but sometimes present sign. The immediate and critical response is to stop the blood pump and clamp the lines to prevent further patient exposure to the cause, such as overheated dialysate or water system contamination. Question 28. In a patient with ESKD, which laboratory findings suggest that the prescribed dose of epoetin alpha, EPO, may need to be decreased?
A.
A ferritin level of 150 nanograms per milliliter.
B.
An intact parathyroid hormone, IPTH, level of 800 pg/ml.
C.
A hemoglobin V, level that has risen from 10.5 g/dl to 13.0 g/dl over 4 weeks.
D.
A pre-dialysis potassium level of 5 milliequivalent/L? Answer: C. A hemoglobin B level that has risen from 10.5 g/dl to 13.0 g/dl over 4 weeks. This question tests the safe management and dose adjustment of erythropoiesis-stimulating agents, ESAs, such as epoetin alpha, in anemia management. The goal is to maintain the hemoglobin B level within a target range, typically 10
to
11.5 g/dl, 10 to 11.5 g/dl, because a rapid rise or a level consistently above 13 g/dl, 13 g/dl, is associated with increased risks of stroke and serious cardiovascular events. Therefore, a rise to 13.0 g/dl, 13.0 g/dl, necessitates a dose reduction or temporary cessation of the EPO to bring the hemoglobin back down into the safer target range. Question 29. A dialysis nurse is preparing to administer the influenza vaccine to a patient. The patient insists the vaccine should not be given in the access arm. What is the most evidence-based rationale for administering injections, including vaccines, away from the extremity containing the arteriovenous fistula, AVF?
A.
To avoid pain and discomfort at the site of the access.
B.
To prevent the risk of hematoma or immediate access trauma.
C.
To prevent lymphedema and subsequent difficulty with cannulation.
D.
To avoid potential localized infection that could lead to access loss. Answer: D. To avoid potential localized infection that could lead to access loss. This is a crucial infection control and access preservation concept. The most significant reason for avoiding injections in the AVF or AVG extremity is the potential risk of introducing a localized infection, such as cellulitis or an abscess, at the injection site. Even a minor infection could spread to the access site, leading to a bloodstream infection, sepsis, or necessitating the surgical removal, excision, of the entire fistula or graft. This is a non-negotiable patient safety rule, and protecting the access from all potential sources of infection is paramount. Question 30. Which clinical scenario is the most appropriate indication for initiating nocturnal hemodialysis? ND?
A.
A patient with acute kidney injury requiring temporary support.
B.
A stable patient with extreme symptoms of restless leg syndrome, RLS, and persistent hyperphosphatemia on conventional HT.
C.
A patient who requires less than 2 kilograms of fluid removal per treatment. D. A patient with a new arteriovenous fistula that is still maturing. Answer: B. A stable patient with extreme symptoms of restless leg syndrome, RLS, and persistent hyperphosphatemia on conventional HT. This question tests the understanding of the benefits and appropriate candidacy for the specialized modality of nocturnal hemodialysis. And NHD involves longer, slower treatment times, typically 6 to 8 hours, 3 to 6 nights per week, which allows for much greater solute and fluid clearance. This improved clearance is highly effective at resolving severe uremic symptoms like restless leg syndrome and achieving better control of challenging conditions like persistent hyperphosphatemia. The increased dialysis dose makes NHD the optimal choice for patients with severe symptoms refractory to conventional treatment. Question 31. A nurse notes that a patient's post-dialysis blood pressure is 95/55 mmHg. The patient is asymptomatic, alert, and denies dizziness. The nurse determines the dry weight may be too low. What is the most appropriate action for the nurse to take for the next scheduled treatment?
A.
Increase the amount of fluid removal by 0.5 kg to test the current dry weight.
B.
Document the blood pressure and notify the nephrologist to request a dry weight increase of 0.5 kg.
C.
Administer a 250 milliliters normal saline bolus at the start of the next treatment.
D.
Recommend a temporary increase in intradialytic fluid intake. Answer: B. Document the blood pressure and notify the nephrologist to request a dry weight increase of 0.5 kg. This question tests the safe, protocol-driven management of intradialytic hypotension and dry weight assessment. A low post-dialysis blood pressure, even if the patient is asymptomatic, is a strong indication that the prescribed dry weight is too low, meaning too much fluid has been removed. The safest and most appropriate action is to document the finding and notify the nephrologist immediately to request an increase or upward adjustment of the dry weight for the next session. Increasing the dry weight by a small amount like 0.5 kg is a cautious, evidence-based strategy to ensure that less fluid is removed during the subsequent treatment, thereby preventing future hypotensive episodes. Question 32. In a patient starting hemodialysis, the nurse notes severe pruritus, itching that is refractory to antihistamines and skin care. Which laboratory abnormality is the most likely underlying cause of this chronic and debilitating symptom?
A.
High levels of serum urea.
B.
Elevated serum calcium phosphate product.
C.
Low serum albumin.
D.
Low hemoglobin. Answer: B. Elevated serum calcium phosphate product. This question links a common, troublesome symptom, pruritus, to its most likely underlying metabolic cause in spKt. Refractory or intractable itching in dialysis patients is a classic clinical manifestation of chronic kidney disease mineral and bone disorder, CKD, often correlated with high levels of serum phosphorus and a resulting elevated calcium phosphate product. The itching is thought to be caused by the deposition of calcium phosphate crystals in the skin, which is why it often does not respond to standard anti-itch medications. Effective control of hyperphosphatemia through diet, phosphate binders, and adequate dialysis is the only way to alleviate uremic pruritus. Question 33. A patient's dialysis prescription includes a dialysate sodium concentration of 135 milliequivalent/L. The nurse observes that the patient often reports feeling very thirsty and gains an excessive amount of intradialytic weight. Which adjustment is the most likely recommendation to help manage this issue?
A.
Decrease the dialysate sodium concentration to 132 milliequivalent/L.
B.
Increase the dialysate sodium concentration to 142 milliequivalent/L.
C.
Increase the dialysate bicarbonate concentration.
D.
Increase the total treatment time by 30 minutes. Answer:
A.
Decrease the dialysate sodium concentration to 132 milliequivalent/L. This question assesses the management of chronic intradialytic weight gain, IWG, and thirst through adjustment of the dialysate sodium. The body is compelled to drink excessive water to match the sodium concentration remaining in the patient's blood after dialysis. This thirst is called post-dialysis osmolar disequilibrium. A lower dialysate sodium prescription, for example, 132 milliequivalent/L, 132 milliequivalent/L, instead of 135 milliequivalent/L, 135 milliequivalent/L, reduces the sodium gradient, which helps to mitigate excessive post-dialysis thirst and, consequently, reduces the large amount of fluid ingested, leading to a more manageable intradialytic weight gain. Question 34. A patient is receiving home hemodialysis, HT. During a training session, the nurse teaches the patient how to safely manage a power outage during treatment. The first and most critical action the patient must take is:
A.
Immediately clamp the arterial and venous lines. B. Use the hand crank to manually return the blood.
C.
Call the emergency contact number provided by the center.
D.
Immediately discontinue the treatment and remove the needles. Answer:
A.
Immediately clamp the arterial and venous lines. This addresses an emergency scenario in a specialized setting. In the event of a power failure, the blood pump stops, but the machine will cease all monitoring and protection functions, and the loss of pressure will cause blood to start draining back into the patient from the arterial line and dialysate to siphon into the venous line. The most critical initial action to ensure patient safety and prevent significant blood loss and contamination is to immediately clamp both the arterial and venous lines to secure the patient's blood volume within the extracorporeal circuit. After the lines are clamped, the patient can proceed with the manual blood return. Question 35. A dialysis unit is converting its entire water treatment system from using chlorine to using chloramines for disinfection. Which component of the water treatment system must be immediately assessed and potentially increased in capacity?
A.
The pretreatment water softener.
B.
The reverse osmosis, RO membrane.
C.
The carbon filter tanks. D. The deionization, DI, tanks. Answer. C. The carbon filter tanks. This question tests specialized knowledge of water treatment requirements related to common water disinfectants. Chloramines, which are combinations of chlorine and ammonia, are significantly harder to remove from water than simple chlorine. Therefore, when a municipality switches from chlorine to chloramines, the capacity and contact time of the granular activated carbon GAC filters, which remove these disinfectants, must be immediately assessed and usually increased to ensure complete removal before the water reaches the patients. Failure to do so would lead to widespread, life-threatening hemolysis due to chloramine exposure in the dialysate.